In pediatric intensive care units, over a quarter of critically ill children will develop acute kidney injury, or AKI. Often, the first observable sign is severe oliguria, a sudden and drastic drop in urine output. Without immediate intervention, the accumulation of unfiltered waste and electrolytes quickly becomes lethal, triggering fatal cardiac arrhythmias as the cellular environment distorts. At its core, AKI is an abrupt loss of kidney function. The glomerular filtration rate plummets, setting off a rapid dysregulation of extracellular volume and electrolyte homeostasis. Diagnosing this decline in real time presents a physiological challenge. Serum creatinine is an insensitive and delayed biomarker. By the time levels rise in the blood, systemic damage is already occurring. To standardize how we quantify this lag and intervene before multi-organ failure sets in, nephrologists use the KDIGO criteria. This chart shows the KDIGO staging of acute kidney injury. It defines the severity of the injury by cross-referencing increases in serum creatinine against strict parameters for urine output over time. Look specifically at stage 3. A patient reaches this critical threshold either when their creatinine spikes to 3 times their baseline or reaches 4.0 milligrams per deciliter, or when absolute anuria, zero urine output, persists for 12 straight hours. Because we are racing against a lagging indicator, diagnosing and managing AKI requires moving past the blood work. We have to map the exact anatomical location of the injury to execute a strict protocol of volume control. AKI functions as a continuum defined by 3 anatomical locations: prerenal, intrinsic, and postrenal. To understand this continuum, we follow the blood flow, starting at the vascular entry point to the glomerulus. Prerenal AKI is caused by systemic hypoperfusion, often from severe dehydration or sepsis. The effective circulating arterial volume drops, leading to inadequate renal perfusion and a decreased glomerular filtration rate without structural kidney damage. If that hypoperfusion is sustained, the injury leads to actual renal parenchymal damage. This is intrinsic AKI, which most often manifests as acute tubular necrosis in critically ill children. Finally, postrenal AKI involves downstream urinary tract obstruction, such as posterior urethral valves, which builds back pressure into the kidneys. This anatomical distinction dictates the urgency of care. Untreated functional prerenal hypoperfusion predictably degrades into irreversible structural intrinsic damage. To prevent this degradation, the first step in clinical evaluation is determining the patient's volume status. Categorizing the etiology anatomically dictates the immediate life-or-death opening move in the critical care triage algorithm. We test the kidneys physically using a diagnostic fluid challenge. This is the physical test to differentiate between reversible hypoperfusion and structural failure. Assuming the patient shows no evidence of baseline volume overload or cardiac failure, the initial move is deliberate intravascular expansion. We administer a rapid bolus of isotonic saline, exactly 20 milliliters per kilogram, infused over 30 minutes. Following volume resuscitation, if the hypovolemic patient voids within 2 hours, the diagnosis is confirmed as functional prerenal AKI, and perfusion has been restored. If there is no urine output, restoring blood volume was insufficient. The hypoperfusion has already caused intrinsic damage, or a postrenal obstruction exists. For non-responders, once circulating blood volume is established, we proceed to a cautious diuretic challenge. A single dose of furosemide or bumetanide is given to force renal cortical blood flow. If urine output still does not improve, a strict pivot is required. All diuretics must be stopped immediately, and the patient must be placed on strict fluid restriction. This restriction is mathematically precise. Intake for the day is limited to 400 milliliters per square meter over 24 hours for insensible losses, plus exactly the volume of the previous day's urine output. The fluid challenge serves as a diagnostic tool, but if structural failure is present, we most aggressively restrict fluids to prevent fatal pulmonary congestion. As urine output fails, we have to manage the secondary biochemical threats of AKI, including dilutional hyponatremia, hyperphosphatemia, and metabolic acidosis. The single most immediate threat to the patient's life is severe hyperkalemia, when serum potassium levels climb past 6.0 milliequivalents per liter. When potassium exceeds the emergency threshold of 7.0, we initiate a 3-step pharmacological cascade. Step 1 is myocardial stabilization. 10% calcium gluconate counteracts the potassium-induced myocardial irritability to protect the heart from arrest, though it does not lower the actual potassium level. Step 2 is intracellular shifting. We use sodium bicarbonate, regular insulin with glucose, and beta agonists to force potassium out of the extracellular compartment and back inside the cells. Step 3 is depletion. We administer a resin like kyaxylate to physically excrete potassium from the body. This chemical shifting protocol is purely a temporary holding action. It buys several hours against fatal arrhythmias while preparing for definitive mechanical clearance. When strict fluid restriction and chemical shifting fail to control the internal environment, medical management has reached its limits. The final stage of the hemodynamic protocol for a non-responsive kidney is the absolute need for dialysis. Dialysis is required when anuria or oliguria leads to volume overload and pulmonary edema that is completely refractory to diuretic therapy. We also intervene for biochemical indications, persistent hyperkalemia, severe metabolic acidosis, or symptomatic uremia resulting in encephalopathy or pericarditis. To provide this clearance, critical care teams use intermittent hemodialysis, peritoneal dialysis, or continuous renal replacement therapy for hemodynamically unstable patients. Once mechanical clearance is established, the patient's ultimate prognosis is dictated by the underlying disease process, rather than the renal failure itself. For instance, AKI from post-infectious glomerulonephritis carries a mortality rate of less than 1. This hemodynamic protocol precisely manages the lethal systemic cascade, maintaining physiological stability until renal parenchymal recovery can occur.